So the final talk in this session is estimating the magnitude of clinical benefit of bisphosphonates and denosumab in the adjuvant setting. Robert Coleman from Sheffield, UK will present.
Thanks, Karen, and my thanks to the organizers for inviting me to participate in this great session. So I'm going to be talking about bone-targeted therapy and the role in early breast cancer. These are my conflicts, which I'll give you a moment to scan through. And I'm going to divide my talk into essentially three sections, a little bit making some observations on some of the biological processes involved in metastasis, particularly metastasis to bone, and then review with you the data that we have on metastasis prevention with the various bone-targeted agents, and then finish up with the clinical application of those data and how we might select patients for treatment. So one thing I think is important to appreciate is that the metastatic process starts very early in the genesis of the disease. Usually before we make the diagnosis, probably before cells have actually escaped the primary tumor, there is release of various factors, exosomes, cytokines, growth factors, which prepare the niche for subsequent metastatic colonization. And that's been quite nicely shown, certainly for the bone microenvironment, where in turn that environment releases factors back to the primary tumor, which initiate the metastatic cascade that we're familiar with. And then as those cells move into the microenvironment, they colonize, in this case, the bone microenvironment and occupy the various metastatic niches, of which there's been a lot of discussion as to the nature of those. This very simplistic diagram just reminds us all that the process of metastasis is extraordinarily slow and inefficient. Many years typically pass between a primary diagnosis and the development of metastasis, particularly in bone as opposed to visceral sites. And this is because of the extraordinary ability of breast cancer's tumor cells to go into a dormant state. And there isn't time in this presentation to discuss this aspect of tumor cell biology, but clearly understanding tumor cell dormancy is a key priority for making future progress in the management of early breast cancer. And here you just see some of the factors that have been suggested to be involved in either pushing cells towards a dormant state or waking them up, and the interaction also with the immune system. And in fact, when you go into the literature, it's extraordinarily complicated. Every cell type within the microenvironment is probably involved. Every hormone you've ever heard of and many you've not heard of is probably involved, as well as many physical factors as well. And so it's not surprising that we've had a great difficulty in trying to understand how to appropriately modify the bone microenvironment to benefit our patients. But one way, of course, a somewhat blunt instrument, is to change bone cell function by applying bone-targeted agents that we more typically use for either prevention or treatment of osteoporosis, or applying to patients with advanced cancer to reduce skeletal morbidity. And it's now 20 years since the first publication by Ingo Deal in the New England Journal of Medicine that suggested that an adjuvant bone-targeted agent could improve disease progression and indeed long-term patient survival. However, it was probably this study presented about 10 years ago that gave traction to this idea of treating the host as opposed to the tumor being something that could add to our well-established endocrine chemotherapy and targeted approaches. And here you see the updated analysis of the ABCSG12 study, which looked at the role of zoledronic acid on a background of ovarian suppression. It also asked an endocrine question similar to the SOFT study, but the key result from this study, as many of you will know, was the observation that 6-monthly zoledronic acid had a significant effect on disease recurrence, which was maintained long after the treatment was discontinued. Shortly after this study, I had the pleasure of reporting a much larger trial that recruited a much broader population of patients. ABCSG12 was young women going through ovarian suppression, all ER positive. Azure and other studies took a much broader population of patients, probably some of the last of the non-selected adjuvant trials, and randomized patients to standard adjuvant systemic therapy alone, or with a fairly industrial schedule of zoledronic acid given for 5 years. And as many people in the audience will know, when we presented this data initially at San Antonio and published in the New England Journal of Medicine, there was no difference in outcome on an intention to treat analysis. What you see here is actually the 10-year follow-up, which shows that that primary result has not changed with the passage of time. But what we also observed at the initial analysis, and that observation is maintained with 10 years of follow-up, was the suggestion that there was a subgroup of patients that might benefit. And these were patients that we had defined as a priori as definitely postmenopausal at study entry. And you can see the impression that the patients on the bisphosphonate are doing somewhat better than those that did not receive the bisphosphonate. Other studies started to suggest the same thing, and of course, essentially, ABCSG12 was a study in postmenopausal women. And this led to a number of hypotheses suggesting that the drugs probably worked on bone recurrence primarily, and that there was an interrelationship between effect and the level of reproductive hormones, or the bone microenvironment effects of those reproductive hormones. And conversely, a possible adverse effect on young patients, particularly in terms of non-bone recurrence. Now, it would have been lovely to have initiated another study to confirm these hypotheses, but rather than wait 10 years or more to get those data, the next best thing was to do a high-quality meta-analysis, and many of you in the audience will be familiar with the EBC-TCG bisphosphonate meta-analysis, which was published a little over 3 years ago, where we were able to assimilate all the individual patient data from all randomized trials, whether disease outcomes was the primary endpoint or that it was essentially a bone mineral density study, and merge all that data in the typical Oxford meta-analysis way to address this question about the value or otherwise of this approach and whether there was a subgroup that clearly benefited. A lot of data was generated. These are the ITT analyses for recurrence, bone recurrence, and breast cancer mortality. And you can see there is relatively little advantage in favor of the bisphosphonate on an ITT analysis. There is an effect on bone recurrence, and there's a borderline effect on breast cancer mortality, but it's not very clinically exciting. But what the meta-analysis did seem to confirm was that there is real benefit in the postmenopausal patients. However you define that, whether that's women going through ovarian suppression, women who are menopausal by virtue of their age, or it didn't seem to matter. These patients all had benefits in terms of disease recurrence, particularly in bone, as you see in the middle, and also in breast cancer mortality, with an absolute gain of about just over 3% at 10 years. So about numbers needed to treat of around 30 to prevent one cancer death. And to put that into context, these are the 10-year relative risk reductions for the other things that we typically do to our patients in the clinic. All these data are taken from the various meta-analyses that relate to these interventions. And you can see that in this postmenopausal group of patients, which of course is the majority of the patients we see in our clinics, then the 10-year relative risk reduction is in the similar ballpark to many of the other incremental additions that we've made to our early breast cancer management. And it's been estimated that the use of bisphosphonates would save up to about 1,000 lives per year in the UK alone. I think that translates to about 8,000 across the European Union. So this, at a public health level, this is an important advance. And since the meta-analysis, there have been a number of guidelines that have been produced, both from this meeting, both from ASCO and North America, and other European guidelines, all of which suggests that an adjuvant bisphosphonate should be considered as treatment in the postmenopausal setting, particularly for women at intermediate to high risk. The observations from the meta-analysis suggested that there was a class effect. It didn't really matter which bisphosphonate you used. It wasn't really possible to define a definite dosing schedule or duration. And the only head-to-head study that we have is this trial from Julie Graylow, which, to my knowledge, has only been presented and not published yet in full, which compared 3 bisphosphonate strategies and also seemed to confirm the indirect findings from the meta-analysis that there is no difference in outcome between these 3 treatment approaches of either intravenous zoledronic acid or daily oral clodronate or abandonate. So what about other targeted agents for bone? So rank ligand is the key signaler for osteoclast activity, and we have a well-established treatment now to inhibit rank ligand, which is the monoclonal antibody denosumab, which, unlike bisphosphonates, which induces osteoclast apoptosis, actually prevents the development of functioning osteoclasts, and was thought potentially to also have some anti-tumor effects, at least on rank-expressing tumors. So we have 2 trials that have addressed the role of denosumab in the adjuvant setting. The first one is also from the Austrian group, ABCSG18. This trial was initially set up as primarily as a trial to look at the effect of denosumab in an osteoporosis schedule, so that's 6-monthly low-dose treatment, look at its effect on fracture incidence in the context of postmenopausal women receiving aromatase inhibitors, with disease recurrence being a secondary outcome. And as you're probably aware, Michael Gannant and colleagues showed very elegantly and clearly that denosumab is an excellent treatment for preventing fracture. It also showed that when you look for fractures, they're extraordinarily common in the context of aromatase inhibitor therapy at around 15 to 20% during a 5-year treatment program, and that frequency was halved. So a number needed to treat of around 12 to 14. More recently, the disease outcomes from ABCSG18 have been published in Lancet Oncology, and you can see that there appears to be a benefit in favor of denosumab in terms of disease-free survival, with a hazard ratio of 0.82, which is statistically significant. Within the paper, though, is a breakdown of the DFS events. You can see that there was an absolute reduction of some 47 events, but I draw your attention to the fact that most of the benefit of denosumab seems to relate to effects on second non-breast primaries, deaths as first event, and a collection of events that may or may not have been distant metastases. It was impossible to say whether they were metastatic lesions or new second primaries. And that actually when you look at definite breast cancer recurrences, there's very little difference in outcome. And so, to my mind, this is an interesting result. It suggests some effect, perhaps, on the underlying disease, but is nowhere near the order of magnitude that we've seen with the bisphosphonates. And following on the back of this is the DCARE study, which was modeled on the Azure trial. And so, again, it used a fairly intensive schedule of bone-targeted therapy using the oncological dosing and a schedule of treatment every 3 to 4 weeks initially, and then 3 monthly. And we presented these data last year at ASCO, which showed that denosumab had absolutely no effect on either the primary endpoint, which was called bone metastasis-free survival, or the more conventional secondary endpoint, which is disease-free survival. And the median follow-up was a little over 5 years, and it's extremely unlikely that those results will change with further follow-up. There was a numerical benefit in terms of recurrence in bone, but this was more than balanced by an increase in non-bone distant recurrence. And so this clearly is not a treatment strategy that can be recommended for our patients. Why might this be? Well, they are different drugs. Their only similarity is that they inhibit osteoclast activity. But bisphosphonates are so-called dirty drugs. They have many effects on cellular functions, some of which are listed there. Which ones are truly relevant in the human clinic cancer situation remains uncertain, but they have many effects on processes involved in metastasis. Whereas denosumab is a much cleaner, targeted therapy. Any effect it has on cancer cells would probably have to be mediated through rank receptors, which are only present in a minority of the patients that we see. So I'm not necessarily surprised that we've seen different results with a different approach at targeting the bone. So how do we apply these treatments? As I mentioned, there are guidelines that have been published over recent years. This is an algorithm that we developed in the UK and which is quite widely being followed, where we ask the question, is the patient postmenopausal? And if yes, is she at significant risk of recurrence? And if so, we give a bisphosphonate, starting with intravenous zoledronic acid during chemotherapy, and then letting patients choose whether they want an oral follow-on therapy or to continue on 6-monthly intravenous treatment. The same would be so for patients receiving ovarian suppression therapy as part of their initial systemic approach. And then for those patients who are at low risk of recurrence, we've suggested 12% 10-year risk, but you can put of breast cancer death, but you can set the bar wherever you like. But we were looking at a numbers needed to treat of around 30. So for those that have a lower risk of breast cancer death, then we would recommend assessing fracture risk and basing your treatment on the bone health aspects rather than the disease recurrence aspects. And if you need to give a bone-targeted agent to prevent fracture, then denosumab is by far the best proven and seems to be the most effective strategy. Lastly, can we predict benefit or indeed harm from adjuvant bone-targeted therapy other than just asking the patient about their menopausal status? Over recent years, there have been a number of biomarkers that have been looked at as possible predictive factors, and I just want to briefly touch on one of them, known as MAF, which is a transcription factor produced from 16q23, and is identified by Roger Gomez's group in Barcelona as predicting for bad outcomes and particularly for the development of bone metastases. We weren't so interested in it as a prognostic factor, but whether it had traction as a predictive factor of disease outcomes in the context of the AZURE trial. And you can see that we managed to perform a FISH analysis for MAF gain on about half of the patients that we had paraffin-embedded TMAs. And that biomarker population had similar demographics and indeed similar outcomes to the main trial. You can see that in terms of the biomarker population, there's no difference between the treatments until you measure MAF. And there you find that in the 80% of patients who are MAF negative, so amplification is only found in around 20% of patients, there is a clear benefit of zoledronic acid, at least in this trial, and this is exploratory, of course, but at least in this trial and exploratory analysis, there's clear benefit of zoledronic acid maintained at 10 years, both on disease recurrence and on overall survival, with a hazard ratio of around 0.7 for overall survival. So we think this is an interesting observation. It's mirrored by, as you might expect, if you have a null result overall, a significantly worse outcome if you're MAF positive and young. These patients seem to do extremely badly, that manipulating the bone microenvironment in a MAF positive young patient sends the disease elsewhere and promotes, sadly, disease recurrence and a worse outcome. So if you don't remember anything else from this talk, manipulating the microenvironment may not always be beneficial. There is the risk to do harm. So some conclusions. I think that the evidence is pretty strong now that adjuvant bisphosphonates both reduce bone metastasis and improve breast cancer survival in postmenopausal women. And it's about 1 in 6 deaths that are prevented. at minimal clinical toxicity or indeed financial toxicity. These are generic, relatively cheap drugs. And I think they should be part of routine adjuvant treatment for postmenopausal women at significant risk for disease recurrence, however you define that. For fracture prevention, denosumab is the treatment of choice, but I don't think we have any clear evidence that it has effect on the biology of the underlying cancer. And we need to do a lot more, as we've been hearing from other speakers, on refining our patient selection through the development of biomarkers. And MAF may or may not be validated in the future, but it's just an illustration of what might be useful in the future. Thank you very much.